Good evening from the UK. My name is Dr. Wale Atoyebi. I'm a consultant hematologist based in Oxford, and I have responsibility for both clinical and laboratory services. I'm very grateful to the Ghana College of Physicians and Surgeons, as well as the Ghana Health Workforce Partnership in conjunction with FET and the Royal College of Pathologists who have commissioned these lectures. Over the next 40 to 50 minutes, I will be talking about benign disorders of leukocytes. Now, this is a very wide area, but I will do my best to touch on the most important aspects, both of diagnosis and approach to management, but importantly, distinguishing between benign and malignant disorders of leukocytes, using some of the newer techniques that the laboratory can provide. So this is the running order of the talk. We'll talk initially about laboratory assessments and then approach to the adult with unexplained neutropenia, followed by looking at some of the acquired and congenital disorders of neutrophils. I thought that Albert Einstein's description, as you can see, is quite appropriate because we do a lot of counting when it comes to leukocytes. But what he says is not everything that can be counted counts, and not everything that counts can be counted. Really interesting. Although we define leucocytosis as the elevation of a white cell count, we must remember that it must relate to the patient's age. As you can see in this table, the white cell count that is acceptable for a newborn infant is very different from that which is acceptable for an adult. And you can see that there are different ranges for pregnant women and infants at 2 weeks. So all laboratories should validate their reference ranges for their patient populations. And as we will see later, there are other factors that might influence what is considered a normal white cell count for a particular individual. So what are the simple conditions that we see on a regular basis that might cause an elevated white cell count? And you can see that for the different components within the white cell line, there are various conditions. Some actually overlap with each other. So common to many of them are inflammatory, infective, and malignant conditions. But there are sometimes more specific conditions, such as those that might be unique to neutrophils, or a chronic form of leukemia unique to lymphocytes, causing an increased lymphocyte count. And we'll see more of this a little later on. If we home in to neutrophilia, which is probably the commonest abnormality of white cells, you can see that based on a patient's characteristics and the potential cause, there's a whole range of reasons why an individual might have a neutrophilia. It's really important, as you will see, is that we need to take a good history. A patient needs to be examined, and then consideration of appropriate investigations to confirm or refute a suspected diagnosis. At the very top, you will see that the patient characteristics are very important. Pregnancy, as we saw previously, age, but also race and obesity play an important role in the actual range of counts that we might see in a given individual. But for most of the others, infection, inflammation are secondary causes. But we must also remember primary bone marrow disorders, either causing a reduction in neutrophils or an elevated neutrophil count, should be taken into consideration, as well as congenital disorders. In terms of the assessment of white cell disorders, everything begins with taking a blood sample. It's important that the right sample is taken into the right bottle and under the right conditions as well. So sampling problems such as difficulty with drawing blood, hemolyzed samples, or samples that have been sitting around for a long time before they are analyzed might produce erroneous results. So really important to remember that this is a typical analyzer that is seen in most laboratories. And it's important to say that what we see as a printout from the analyzer is just the summary of a huge amount of data that is generated for every sample. So if you go back to the machine and look, you'd see probably up to 3 pages of parameters for a given patient, which we don't use on a regular basis, but might be useful for statistics and further research. The third image shows cells being resolved by their size and their fluorescence, and as you can see, the different cells are separated. So this image shows various disorders of the myeloid series, various disorders that cause a raised white cell count, from A, which is a reactive leucocytosis due to a perforated tumor, to F, which is a very rare disorder unique to the eosinophilic cell line and defined by a particular genetic aberration as part of a syndrome. So what you see is a range of disorders. D is chronic myeloid leukemia, and you see a bimodal distribution of both neutrophils and myelocytes. This slide shows a lymphoid leukocytosis or a lymphocytosis, starting from image A once again, which is a reactive lymphocytosis due to glandular fever caused by the EBV infection, right up to the last 6 showing various forms of chronic lymphoproliferative disorders. And there are subtle differences between the cells. They are all malignant, but actually morphology on its own is not enough to make a diagnosis, and we'll talk about some of the tools we can use to differentiate the different types of both benign and malignant lymphocytosis that we encounter. Over the last few years, there have been advances in digital morphology, both in hematology, histopathology, and other areas such as microbiology. In the hematology lab, an appendage to a standard analyzer will allow automated production of blood films, and these are read digitally and can be accessed by scientists and hematologists either in the lab or remotely. The quality of these images can be really good, but also importantly, it picks out small numbers of cells that might not be easy to pick up when you look down the microscope. So this is what it would look like, and the advantage, like I said, is to be able to access these images remotely, especially in difficult situations, for example, during a pandemic, and it allows remote reporting and the fact that you don't physically have to be in the laboratory to report a blood film. An additional tool is flow cytometry. It uses a particular technique to identify a population of interest. These cells are resolved by their expression of particular markers unique to cells. A third area of interest is molecular diagnostics, both targeted gene mutations, but also next generation sequencing, as this image shows. This technique has had a huge impact in our diagnostic utility, both of benign and malignant disorders of white cells, and the utility continues to widen with time. Well, if we go back to the basics of lymphocytosis, what you see here is a huge range of causes of a reactive lymphocytosis, uh, commonly infections of various types, but we must not forget disorders such as autoimmune disease, smoking, post-vaccination, and major stress, as well as endocrine disorders, can all cause a reactive lymphocytosis. As an example of a reactive lymphocytosis, this image shows a large number of lymphocytes. You can see they're very big. They've got quite a large volume cytoplasm. But what these cells are also doing is they're creeping around the red cells, which is a characteristic of reactive lymphocytes. And some of them have granules in them, described as large granular lymphocytes, commonly seen in viral infections. Attempts have been made to classify reactive lymphocytes, and you can see three different type classifications here, from smaller size to type 2, which is the most common type, like the ones we've just seen, to quite large ones with nucleoli, very basophilic cytoplasm, and almost look like primitive cells and can easily be mistaken for primitive blasts, especially to the inexperienced. What are the features that might suggest that a lymphocytosis is malignant rather than benign? Because it's really important to be able to differentiate. The typical scenario is that a sample comes into the lab on a Friday evening, you're at work, preparing to go home, and you're confronted with a lymphocytosis. And the question is this a benign or a malignant lymphocytosis? Because your approach to management is going to depend on what that finding represents. The history, as always, is important. So the history of infection might be more suggestive of a malignant cause. The other symptoms, such as night sweats, weight loss, and other systemic symptoms, might also point to a malignant cause, but we must not remember that those symptoms can also be found in benign causes. Physical examination is important. Is there lymphadenopathy? Is the spleen or liver enlarged? Can you feel any masses? What about in the laboratory? From the very basic of tests, the red cell count, hemoglobin measurement, platelets, and what do the cells look like down the microscope? Do they look mature or do they look immature? All these put together begin to form a picture as to the possible cause for your leucocytosis, be it neutropenia or lymphocytosis. What tools can we use, though, to differentiate between benign and malignant lymphocytosis? The flow cytometer is a really precious aid to diagnostics, especially of lymphocytosis. And the technique is as shown. Cells are acquired, they are labeled with antibodies, which are specific to cell types. A laser beam is shone through and fluorescence is detected. The cells are resolved by both their size and their fluorescence, as you can see. Every cell expresses particular antigens, and knowing those antigens and the presence of the antibodies to those antigens allows to mark individual cells and pull them out in flow cytometry. So you can see the different myeloid precursors and mature myeloid cells and the markers that they express. Similarly, for the lymphoid cell line, be it T cells or B cells, early or late cells, there are markers that form a pattern for each cell type, and that helps us in diagnosis using flow cytometry. So if we look at a couple of examples, This is a 42-year-old lady who smokes, presents with a 4-month history of lymphocytosis, was referred to a hematologist with a suspected lymphoproliferative disorder. On examination, there was no lymphadenopathy or hepatosplenomegaly, and CT scans were unremarkable. So you're confronted with these lymphocytes. There's a normal hemoglobin and platelet count, but the question is this malignant or benign? It's important to note that lymphocytes can really look pleomorphic and can be difficult to with confidence determine the origin. So you have a differential diagnosis. First, B-cell chronic lymphocytic leukemia, which is the commonest leukemia in the world, or is this a unique polyclonal B-cell lymphocytosis? So immunophenotyping has picked up a population of cells which are specifically marked on the by these CD markers, but importantly, there's no light chain expression, and therefore the diagnosis here is one of a polyclonal B-cell lymphocytosis, which is unique to middle-aged women who smoke and associated with a polyclonal hypergammaglobulinemia. Another example is a 23-year-old gentleman who presents with fevers, muscle aches, and abnormal liver function tests. White cell count is elevated with a lymphocytosis, and on the blood film, these cells are seen. Initial impression is that these cells look reactive. They're similar to one of the images we saw earlier on. They've got large volumes of cytoplasm wrapped around red cells, and you can see some small granules in them. So the question is this a large granular lymphocytosis, or is it a malignant T-cell disorder? And once again, immunophenotyping has helped us because it's characterized the cells. These cells are marked as CD8 cells and with a number of other T-cell markers. Some are aberrant, but this pattern is more in keeping with a large granular lymphocytosis. In the presence of confirmed EBV infection, we can be confident that the diagnosis here is of a large granular lymphocytosis of reactive origin rather than malignant. So this summarizes the investigation of an individual presenting with an elevated white cell count. It looks very complex, but actually it follows the usual working patterns of diagnosis. So you look at the blood film and you consider whether you've got an elevated myeloid or lymphoid population, and that determines your direction of play and further investigations. But what you're using is a combination of immunophenotyping, morphology, as well as molecular diagnostics to make your final diagnosis. So how do we approach an adult with unexplained neutropenia? I think it's really important to initially start by defining the different types of neutropenia. In general, neutropenia is defined as a neutrophil count of less than 1500, or depending on what units you're using, 1.5 in an adult, and can be classified as mild, moderate, or severe. Severe is less than 500. Agranulocytosis doesn't mean the complete absence of neutrophils, but it means a neutrophil count of less than 200, and this is of course associated with a significant risk of severe infection. Chronic neutropenia is explained by neutrophil counts that are reduced for greater than 3 months. Constitutional neutropenia tends to suggest a congenital or inherited neutropenia, and isolated neutropenia means that there is no associated anemia or thrombocytopenia. Neutropenia can be classified in different ways, using the usual descriptions of congenital, acquired, idiopathic due to increased consumption or reduced production, or increased destruction, and there are various causes. Probably An easier classification is into acquired and congenital, with the commonest acquired causes being that of infection, immune mediated, such as autoimmune diseases, a long list of drugs, and infiltrative bone marrow disease, which tends to be malignant. On the congenital side, we can see a number of disorders here. Many of them are quite rare, but the one that's probably most unique to Africans is the benign ethnic neutropenia, and I'll touch on all of these forms of neutropenia. So, which drugs cause neutropenia? Well, there's a whole list of them. Chemotherapy by default causes neutropenia, but a number of common drugs that we use, including antibiotics, non-steroidals, which are quite frequently used for a number of medical problems, antihypertensives, and neuropsychotropics, all potentially cause neutropenia. And sometimes the only way of confirming the agent as the cause is to hold the drug, if at all possible, for a period of time. As mentioned before, we divide neutropenia into mild, moderate, and severe, and this just represents the risk of infection with neutropenia. When the neutrophil counts are greater than 1, the risk of infection is fairly mild, but once the neutrophil counts fall to less than 500, then the risk of significant infection is high, and most patients will need an inpatient admission with parenteral antibiotics. When the neutrophil counts are less than 200, then there's a very significant risk of infection, and urgent intervention is required if any clinical signs of infection are up. In the evaluation of neutropenia, we follow a fairly standard scheme. We look at the blood counts, look at the blood film, and then run additional tests depending on our suspicions. And ESR and CRP are very useful for identifying infection and inflammation. Immunological tests help us to screen for rheumatological conditions. We must not forget simple things such as hematinics, B12, folic acid, and iron deficiency. All of them can be associated with neutropenia. Less commonly, mineral deficiencies. A bone marrow examination is not infrequently required, importantly to exclude infiltrative disorders as well as hematological malignancies such as myelodysplasia and acute myeloid leukemia. Immunophenotyping can be very helpful. A particular condition associated with neutropenia is large granular lymphocyte leukemia. This is a chronic T-cell lymphoproliferative disorder and commonly associated with neutropenia. But also importantly, the utility of molecular diagnostics and targeted gene mutations as well as next generation sequencing is playing a larger role in diagnosis of blood disorders and neutropenia as well. We'll look at a few examples of acquired neutropenia. One is present at a very early age, described as neonatal alloimmune neutropenia, not very dissimilar to neonatal thrombocytopenia and rhesus disease of the newborn, which of course affects red cells. Not uncommonly, maternal antibodies to paternal antigens are the cause and affect fetal neutrophils, causing destruction. Usually resolves spontaneously over weeks or a few months, but sometimes associated with infection. So infection, of course, needs to be treated, but testing of parenteral blood will help with diagnosis. Autoimmune neutropenia can affect an individual at any age, often triggered by infection, but might be part of a broader autoimmune disorder. And Feltis syndrome comes to mind. This is a disorder which comprises neutropenia, splenomegaly, and rheumatoid arthritis. So this form of autoimmune neutropenia is part of an autoimmune disorder. And in a proportion of cases, anti-neutrophil antibodies are positive. The management is supportive. Antibiotics for infection. GCSF is commonly used to stimulate neutrophil production because this is a peripheral destruction, and sometimes steroids as well as intravenous immunoglobulins have a role. It's chronic, but most patients actually don't run into problems. I'd finally like to touch on some of the congenital neutropenic syndromes. And so I've shown a list again, and I'll just touch on them because many of them are quite rare. We should look at neutropenia in the context of systemic disorders which are inherited or are congenital, which have neutropenia as a component, as opposed to syndromes where neutropenia plays a major role or is the underlying problem. So all these disorders, which are extremely rare, are associated with quite severe neutropenia potentially. The diagnosis can be challenging. Next generation sequencing has actually played a major role in facilitating early diagnosis of these disorders in the laboratory. This is one example, myelocathosis, and the image that we see shows a bone marrow smear from a patient with this disorder. And what you see is unique neutrophils with odd lobulation, but importantly, you can see that the strands between the lobules are quite thin filaments. You don't usually see that in normal neutrophils, and it's characteristic of this disorder. There's the chronic benign neutropenia of childhood. Usually the neutrophil count is less than 0.5 or 500, but interestingly, not associated with significant infections. It's usually a diagnosis of exclusion when all other causes of neutropenia in childhood have been exhausted. There's no suggestion that counts are cycling. Bone marrow looks normal, and in a proportion of patients, anti-neutrophil antibodies are detected. If infections occur, treatment with a neutropenic regimen of antibiotics with GCSF usually is sufficient to overcome infections. At the other end of the spectrum is the severe congenital neutropenia called Schwachman-Diamond Syndrome. This is very rare and even rarer in people of African origin, but it does present very early in life with recurrent pneumonia and abscesses. There's a complete inability to make neutrophils, and most of the time the neutrophil count is very low, less than 200. It's probably the equivalent of a red cell aplasia, such as the Schwachman-Diamond Syndrome that we see in red cell aplasia of a congenital type. This is typically diagnosed in infancy. It's autosomal dominant. The abnormality at the genetic level has been elucidated and involves mutations in the neutrophil elastase 2 gene. And this can be picked up in up to 70% of patients presenting with this syndrome. Treatment is, of course, antibiotics for infections. Some patients will benefit from long-term colony stimulating factors such as GCSF. The Schwachman-Diamond Syndrome is another congenital disorder where neutropenia is quite apparent. It's caused by a number of variants, but the SBTS is probably the best described mutation. It's inherited as an autosomal recessive disorder, and it is characterized by really a triad of neutropenia, pancreatic insufficiency, and short stature. It tends to present in the first 10 years of life with the features of pancreatic insufficiency, so failure to thrive, short stature, diabetes, diarrhea. The diagnosis might be suspected, especially when infections ensue and there's persistent neutropenia. Physical anomalies are quite common. The risk of this is that although it is a benign disorder, the myeloid component, which is represented by neutropenia, has a propensity to transform to malignant myeloid disease in the form of myelodysplasia or even acute myeloid leukemia. So there's a continual surveillance by hematologists looking after these patients to make sure they're not transforming, and if they are, to be able to pick it up. So it's a complex disorder, as you can see, with a wide range of abnormalities involving the pancreas, myeloid series, potentially causing myelodysplasia, acute leukemia, and even some cognitive associations as well. An interesting syndrome is cyclic neutropenia. This is seen in all races, and what we see is a dip in neutrophils which occurs around 3 to 4 weeks on a continuous basis, and these patients actually present with an absolute neutropenia at that time and are at risk of quite severe bacterial infections when the neutrophils are at their nadir. The approach to diagnosis is initially to take a blood count 2 to 3 times weekly for up to 12 weeks, and what you see is a pattern of falling neutrophils and spontaneous recovery. And with that pattern repeatedly shown, there's a strong index of suspicion of this disorder. It is inherited in an autosomal fashion, and once again the neutrophil elastase gene is responsible in terms of a mutation and can be confirmed by molecular diagnostics in specific laboratories that have the capacity to do this. Management is once again with antibiotics, broad spectrum for infections, and for some patients the use of GCSF on a long-term basis if they recurrently present with infections. Closer to home is the benign ethnic neutropenia, and this form is quite interesting. It seems to affect individuals of particular races, most commonly individuals of African descent, but less commonly individuals from Europe and the Middle East. So additionally, it will be found in individuals from the Caribbean because of their genetic background. And it presents with a constitutional neutropenia. It's not usually very severe, but neutrophil counts are less than the normal that's expected for aged matched controls. Not usually associated with recurrent or unusual infections, no other blood count abnormalities. There are no specific physical findings, and usually find no associated causes. you might know that it is associated with the Duffy null phenotype, which is the Duffy A and Duffy B negative blood groups. And we know that this phenotype is common to individuals of African descent. A single nucleotide polymorphism in the Duffy coding gene is responsible for the neutropenia that is found very commonly in Black individuals. And I will be referred patients in my clinic from GPs in the UK who have a mild neutropenia, very commonly just looking at the name and the ethnic origin would give a potential reason for their neutropenia and prevents unnecessary investigations. And I'd be happy with a patient with a neutrophil count of as low as 750 in this context. But what we do know is that even though individuals might be homozygous for the polymorphism, not all of them present with neutropenia. Importantly, the Duffy null phenotype is protective against severe malaria, and it's one of a number of genetic factors that protect individuals of African origin from severe malaria. So in summary, I hope I have given you a flavor of benign white cell disorders. Importantly, to always focus on distinguishing the benign from malignant disorders, because it has a major bearing of how we manage these disorders, and that we can utilize all the tools at our disposal, starting from the history and all the way to the most complex and innovative genetic tests. We have the advantage of quite sophisticated analyzers, and digital morphology will be increasingly used in the future. The diagnostic innovations of immunophenotyping, molecular diagnostics, and next generation sequencing are going to be increasingly used in diagnosis, but also therapeutic interventions with wider spectrum antibiotics, supportive care, and growth factors such as GCSF, etc., all contribute to improved outcomes. So with that, I will end this lecture. It's been a pleasure providing it, and have a nice evening. Thank you very much for listening.